Okay, welcome, pharmacology friends. We're gonna redo this one. Well, hey there, pharmacology friends. We're going to take a look at one of my favorite topics today, and that's cardiac medications. I love the heart. I think it's an amazing machine. It's electrical, it's physical, it has a lot of complexity, but it's also pretty simple all at the same time. So, without further ado, let's take a look at the heart. Now, one of the best ways to understand medications for the heart and the circulatory system is to ask yourself, well, what can go wrong with it? Well, first, the heart is a pump. It's an electrical pump that has the EKG. It's a mechanical pump that's moving blood around, and so we can have different types of issues that affect the heart. The electrical ones can affect the heart rate. Mechanical issues that can affect the power, the amount of squeeze that the heart has during systole, or distribution, like a clog in the blood vessels that are leading out of it, or maybe something like angina, which is a clog or a clot with the little cardiac uh, vessels that are feeding the blood to the heart to give it oxygen so it can work. So, mechanical pump issues are things like low pump volume or a low cardiac output, or maybe a weak pump strength that you might see with cardiomegaly um, from congestive heart failure. Electrical heart issues are going to be things like pumping too slow to get the amount of blood to the body, like with bradycardia, or pumping so fast that the pump isn't effective, like supraventricular tachycardia. You can have distribution issues like a clogged hose leading to high pressure in the pipe. And it could be like high blood pressure or a clot. Or you can have clots or garbage that clog the pump or the pipes. Or you can have a leak in the pipe, like if you cut yourself and you're bleeding out and now you're hypovolemic. Now, that's not going to work so well. So, the summary, the main type of cardiac meds all have to do with how they just kind of these issues. Let me fix this typo. So we can have vessel issues like increased blood pressure, and sometimes we want to do that. We need to increase the blood pressure, and so we want to add something like vasopressin or levofed or angiotensin 2, and we want to do this for some types of shock. If the blood pressure is really low, and we need to get it higher because the person doesn't get enough blood profusion, or maybe we need to decrease the blood pressure. We need to dilate the veins with some nitroglycerin, or dilate the arteries with a calcium channel blocker. Maybe we can use a diuretic, or to remove some of the fluid volume, or maybe we need to slow down the heart rate using some beta blockers, which also have an effect on the ability to create some vasodilation. Or you have ACE inhibitors and ARBs. We use nitroglycerin for things like chest pain. We use calcium channel blockers for things like Raynaud's and vasospastic angina, and we'll talk about that a bit more. Diuretics for high blood pressure, and beta blockers, and ACE inhibitors for high blood pressure. Sometimes we need to increase the speed of the heart, and we use an anticholinergic like atropine, and we do that for bradycardia. If the heart's not beating fast enough, we need to get that speed up, or maybe we need to decrease the heart rate there. We need to use a beta blocker, for something like tachycardia. Or we need to change the pump strength. Maybe it pumps really weak again because of heart failure, and we need to use a cardiac glycoside like digoxin, or we need to decrease the pump strength because it's too much and it's causing chest pain. And so we might use something like calcium channel blockers to reduce the amount of squeeze, therefore the amount of effort, therefore the amount of oxygen that the heart is using when it pumps. So we're going to go through all of this a little bit, but first, some terms that can help you understand these things. And I'm just kind of going with a really high, big overview of everything, like a 50,000-foot view. And then we're going to bring it down to just kind of look at sort of the main classes sort of briefly. We don't want to go too deep here or get overly deep. That's here where it gets overwhelming. But let's take a look at the heart and some heart terms. So we have the preload, which is the volume of blood that's in the ventricles at the end of diastole. Now, remember we have systolic or systole and diastole. And so systole is where the heart squeezes and depolarizes. That's the big pump with the left ventricle and right ventricle. So that's systole. And then everything relaxes in their diastole. That's when the pump and everything just kind of opens up and relaxes. The heart is able to be fill again. So then it can squeeze, and it's just like a pump. And I don't know if you ever did this when you were in a pool. You squeeze your hands like this and squirt your siblings in the face with water, or maybe I was the only one that did it. But that's a whole lot like what's going on with your pump. So we relax it, and it fills up, and we squeeze it really hard, and it shoots the pump. And the harder we squeeze it, and the faster we squeeze it, the more pressure it generates. The same is true with your heart. It's pretty cool. So when we have increased preload, we see that with things like hypervolemia, which means too much volume of blood, or like high blood pressure, or things like that, or regurgitation of the cardiac valve. I have aortic valve insufficiency because I have a bad aortic valve. It leaks a little. So I end up with more blood in my left ventricle because I have some that's coming in from the left atrium, and then I have some that's leaking back through my aortic valve. So I have an increased preload in my left ventricle. You can have afterload, which is the resistance that the left ventricle must overcome to circulate the blood. And so that's things I like to think of it as a lot like blood pressure. So the more afterload is more resistance, and so it's like the amount of pressure that the heart has to push against. And if I can reduce the amount of afterload, the amount of pressure it's pushing back on the blood, or that left ventricle has to push against, that can decrease the amount of pressure and the amount of effort that my heart has to do. And so that's one of the things that we have to be careful. And one of the things, like if you have high blood pressure for a long time, it can cause left ventricle hypertrophy, which means that it's getting bigger because that muscle needs to get stronger so we can push even harder to get that blood out. And if we can release that or reduce that afterload, we can reduce the cardiac workload. And so that's one of the reasons why we do things like ACEs and ARBs and vasodiuretics and things to reduce blood pressure. And we'll talk a little more about that. So now we have cardiac output. And cardiac output is equal to your heart rate times your stroke volume. Now, your stroke volume is on average about 70 milliliters. And so my cardiac output is equal to my heart rate times my stroke volume. So for easy math, let's say my heart rate is 100 beats per minute, and then I am pushing out 70 milliliters. That means I'm pushing out about 7,000 milliliters. Is that right? Did I do that math right? Yeah, I think so. At a minute. So that's quite a bit of blood. About 2 gallons of blood, I think. Not quite, but pretty good amount of blood happening there in a minute. And sometimes we need to increase the cardiac output, and sometimes we need to decrease the cardiac output. Again, because that we need to balance homeostasis. So some terms that you might need to know for your tests. So one is called inotropic. And so the word ino means fiber. The word tropic means to change. And so all these words end in tropic. That's a Greek word. And ino means fiber, like muscle fiber. And so you can think about that as the amount of force of the muscularity or the muscular contraction of the heart. So you can think of like some guy, I know, and it's a forceful heart. I know it's a forceful heart. And so the bigger the inotropic effect of that medication that we might give, the stronger that pump squeezes. And that means the more pressure it has. And so we you'll see positive and you'll see negative in these types of things. So positive increases the effect, negative decreases it. So the main positive inotropic medication is digoxin, and digoxin increases the amount of pressure that the heart is able to do, the amount of squeeze. And so it's just like you're squirting the water to faster and more forceful so you can get that volume of blood out to increase that cardiac output. Um, and so you might see that in someone who's got congestive heart failure and their heart's floppy and it's like weak. And so we can give digoxin to make it dig deeper. And so one way, the ways to remember it is to think that digoxin, DIG, it's often called dig or digitalis, it digs deep for a stronger contraction, digs deep for a stronger contraction. Now we have chronotropic action, and you can think of chronotrope or like a chronograph on your watch. That's the little thing that you use. The stopwatch is called a chronograph. Chronos is the Greek word for time. Um, and so chronographic is like time is the um, heart rate. It's the amount of how fast it goes. And so a positive inotrope, or I'm sorry, a positive chronotrope is going to increase the heart rate. It's going to increase the heart rate, a positive chronotrope. And that's going to be things like epinephrine. Epinephrine stimulates the beta cells in the heart and it causes it to fire more quickly. Epinephrine, norepinephrine. Um, a negative chronotropic action. So negative means it's going to decrease that. So negative chronotrope means it's going to decrease the heart rate. And a good example of that is a beta blocker. Now we have a dormotropic action, and dormo is the Greek word for road. And so I was trying to come up with a good mnemonic to remember dormotropic because we don't use that word a lot in English. And so I came up with this mnemonic to think of the speed of an electric car driving on a motorway. DR for driving on O motorway. DROMO, dromo. Because it's the speed of the electrical conduction through the heart. And we'll talk more about that when we get to calcium channel blockers here in just a minute. So a negative dormotropic medication slows the heart rate down, or slows the heart rate down some, but it's more focusing on slowing down the conduction velocity of the heart, more slowing down the conduction velocity, which is how fast the heart depolarizes. That's different than heart rate. Heart rate is like beats per minute. So if I'm running fast, my heart rate might be 100 or 120 beats per minute. But we're not talking about beats per minute. We're talking about the length of time that it takes for my heart to depolarize and repolarize. It's mostly in the depolarization we're interested in here. And a dormotropic medication slows that down. And we'll get there in a minute, I promise. And there's a really good, clear understanding here when we talk to calcium channel blockers, which is a really good example of a negative dormotropic medication. So if it's the depolarization is happening too fast, then the pumping action is not going to be effective. If it's too slow, then that could be a heart block and might lead to a fatal arrhythmia like ventricular fibrillation. So we want to get that dormotropic action just right. And another word, I've never heard of this one, but it's called lusitropic. And you can think of all relaxed and loosey-goosey. Lucy, it's Lusi, lusitropic. And really what a lusitropic medication does is it influences the relaxation of the heart muscle during diastole. And the more relaxed it is, and the faster it relaxes, the more it can fill with blood because it fills with blood when it's relaxed. Think about yourself, a little self-care analogy here. If you're constantly just pushing it out all the time and you're not taking any time to relax, to refill your well, are you going to have anything left to squeeze out? No, no. So lusitropic, all loosey-goosey. And so the heart gets filled up at diastole when we just want to get relaxed. So relaxed we could die, right? Diastole, relax. That's good. We want to be more diastole. All right. So let's take a look at these major cardiac med classes. And this is kind of going back to that high level overview of what can go wrong with the heart. I'm really just trying to keep things here in a way that can help you all conceptualize them. One way is to look at the effect on the distribution network or the pipes, the blood vessels that are coming off of this pump. So given the same amount of fluid, the skinnier the pipe, the greater the pressure. So it's like, I don't know, I do this all the time. When I'm watering my plants and I need to get that water further, I put my thumb on the end of the pipe and I'm squeezing and I'm reducing the amount of area that the water can come out, and I'm increasing the pressure, which causes it to shoot further, right? Same deal here. Or say you've got, you've got 100 gallons of water and you try to put it through a straw. Well, you might have higher blood pressure or higher pressure than if you put it through like a 4-inch pipe, right? The skinnier the pipe with the same amount of volume, the greater the pressure. So keeping that in mind, a vasodilator decreases blood pressure by dilating or opening up the blood vessels. So that's what vasodilators do. They open up the blood vessels. And by opening the blood vessels, we are getting a lower amount of blood pressure. An example of this is nitroglycerin. And I think of nitroglycerin, Nitro, nitro. Most of them will have nitro or nitrate in the word. And think of that nitro works mainly on the veins. And the way I remember that is Ni for nitro works mainly on the veins, IN, in veins. And so it's kind of, it's like a palindrome, if you will, with the NIs. If you can take a look at your notes, you'll see what I'm talking about. Another example is a calcium channel blocker that doesn't have a lot of effect on the veins. It's mostly on the arteries. And so the way I think about that is calcium, like dairy, blocks my arteries, right? So calcium blocks your arteries. It actually relaxes the arteries, but it's the way I can remember that calcium blockers work on the arteries more so than the veins. So not a perfect memory trick because you can be a little bit confusing there, but you can think that my dairy that I eat affects my arteries. That kind of works. And then you have vasoconstrictors, and those are things that increase the pressure by constricting the blood vessels. And we will use these in the ICU for types of shock like epinephrine or angiotensin 2 or levofed. So maybe somebody's got sepsis and their blood pressure is just garbage because of all that massive vasodilation. Well, we're going to try to give a medication like levofed to cause some blood vessel constriction so we can get some increase the blood pressure if it's too low, because if the blood pressure is too low, we don't get enough blood perfusion to the organs, and then things start to die. We get multiple organ dysfunction and death. And so levofed and vasoconstrictors can be very important depending on what's going on. So another thing that is a really good thing to try to grasp here is angina. Angina is chest pain that is due to a lack of blood flow or oxygen to the heart muscle. So I don't know if I'm the only one who might have been confused by this, but I kept thinking, I'm like, the heart's got plenty of blood. It's moving gallons of blood a minute, right? And I'm like, well, no, it's just got these little tiny cardiac arteries and veins that are just on the outside of the heart itself. And that's what feeds the pump. It gets blood and it needs blood too, just like all the other organs we have and all the other muscles that have. It needs a lot of blood, and it needs a lot of blood. And so it has its own little blood network, its own little blood vessel network. And these are the ones that get clogged that cause myocardial infarctions. This is when these things get blocked, people die from an MI, or myocardial infarction, from death of the heart tissue. So they're basically, angina is a muscle cramp. It's chest pain, and it's basically a muscle cramp that's caused by a lack of oxygen to the heart muscle. The same way, like when we're doing leg day and we go into that anaerobic activity and we're pushing and we get sore the next day and we got that lactic acid buildup, that's what's going on with the heart. Except for it doesn't usually take a day to tell us that it didn't get enough blood. It usually just like, "Ugh," and you're done, right? So, but angina, there's a couple of different kinds. So angina is basically a muscle cramp of the heart caused by a buildup of lack of oxygen or other things, of lactic acid or other things. So look in here, if you're trekking along with your handout, there's a nice illustration here of some different types of angina. So here's you have at the top a normal coronary artery, and these are the arteries that feed the heart, the coronary arteries. That's why I say don't have a coronary. That's where it comes from. Then you have stable angina, and this is from atherosclerosis. You hear this? See this? Athero? That means crap and build up of cholesterol because you've been eating way too much bacon. Yep. Sorry. This bacon. This is bacon right here. That's what arteriosclerosis happens with bacon, and it happens if you smoke a lot. Yeah, you don't even need to smoke a lot. It just causes a lot of the toxins and the nicotine and some of the other things with smoking is really bad. So bad news. So any arteriosclerosis can cause stable angina, and stable angina is say you're walking and you're exercising and you're starting to get some chest pain. And then you call your doctor and they're like, well, take some nitroglycerin. You put it on your tongue and it feels better in about 5 minutes. Well, that's because that's released. And we'll talk about that in just a moment here. But that's stable angina. And it's usually caused by a narrowing of those uh, coronary arteries because of the garbage here in in the little blood vessels that are feeding your heart muscle. There's unstable angina, which is what happens with atherosclerosis, and you get a blood clot on it. Now, these blood clots can chip off, and if that blood clot keeps going on down, and as it will, if it's through the blood vessel and keeps on going down and gets stuck, it's going to kill whatever's on the other side of that blood vessel. It's going to stop the oxygen needed blood from getting to wherever. And if that's in the left anterior descending coronary artery, that's the widowmaker. And, I'll tell you, you're going to die. So this is why we need to look at other medications down here that do things like help reduce cholesterol. And this is why stents work. Stents will come in here and we will we'll push open these little areas of these clogs with the stents. And then here's one that's not related here, variant angina. It's also called Presmetol's angina or vasospastic angina. And this is just a coronary spasm. It's not necessarily, there's no garbage in there, but this can be caused from things like smoking or vasoconstrictive medications or cold or stress or exercise, cocaine, other types of drugs. And so the whole idea with all of these types of medication is to increase the oxygen supply to the heart tissue. And the pain that you're feeling is that coronary artery spasm. And so we want to relieve the pain, but we also want to relieve the hypoxia that's happening to that tissue, because if the tissue is gets a little bit damaged, we can have a myocardial infarction, or we can have cardiac cell death in the heart. So then we get go back to a little bit here with stable angina. Those are most often caused by exercise, so physical activity, because blood's diverting to the muscles maybe, and it's the heart's not getting enough blood, or maybe you're really super excited and there's some sympathetic nervous system happening, going on, activation, and some other things that are happening, and so blood's going everywhere, maybe going to your muscles again so you can run, or maybe you ate a really large meal and now your body's trying to digest and you're got like a bad heart, and so now you're getting some pain there, or maybe you're cold so you're shivering and your metabolism's building up, because you've got all of that muscle movement going on and constriction happening, so you can generate some heat. That's happens when you shiver. That's what's happening. And so mostly it's caused by coronary artery disease where plaque builds up, and then the pipes have clogs in them, and so the blood's just not effective. So the goal is to reduce the amount of myocardial oxygen demand. That's a fancy way of saying we need to tell the heart to chill out. Chillax, man. Chillax. So we can do that by slowing the heart rate. We can reduce the force of contraction so it's not doing this all the time. This takes some energy. But if we can make it just kind of go, okay, this is a little bit nice. Yeah, let's go a little slower. Let's reduce the preload so it doesn't have to push as much blood out. Let's reduce the afterload so it's all chill and those blood vessels are nice and wide and open and now it's going with the flow. And that's what we want to do with these medications. And you'll see when we get into these meds a little bit more how they start to work. So then we have unstable angina, which is a heart attack waiting to happen. That's going back up here to our image. That's this blood clot that's hanging out on top of this narrowed artery with some coronary artery with some there. So that's basically a heart attack waiting to happen. And if somebody comes in with a suspected myocardial infarction, we're going to give them Mona. And Mona could be a really sweet old lady, but in this case, it stands for morphine, which helps to reduce the pain that they're feeling because that's hard. That hurts, that heart pain. That's hard. That's a hard pain to have. And then when you're in pain, you increase your sympathetic activation due to pain, and morphine helps reduce that. So it helps to relax things. It helps. It's a good drug for this. Oxygen helps you not die because you're not getting a lot of blood oxygenation to the heart. If we can start hyperoxygenating someone, that can get whatever blood that we can get to their heart muscles. On the other side of that clot, we can give them better quality blood, if that makes sense, more oxygen. Nitrates cause vasodilation again, and they reduce preload on the veins, but they also work on the coronary arteries. They work on the coronary arteries. It's kind of the neat place where nitrates work the best, which is why people take nitroglycerin under the tongue, and it goes immediately into their bloodstream. And then aspirin, which helps to prevent platelet aggregations or clots. So some other treatments for angina pectoris, which is chest pain. Or is it, it's angina or angina. I guess it depends on what part of the country you're from. Angina. So you can use a calcium channel blocker that reduces the cardiac workload by causing arterial dilation, which helps relieve vasospasms as well. And it reduces afterload. We'll take a look at that in just a moment. And then you can use a beta blocker. We talked about that a lot in our first exam when we're talking about the sympathetic nervous system, but it reduces the cardiac workload by slowing the heart rate, and it causes some vasodilation. And that's a good one for that stable angina. It keeps that heart rate lower. And so, like, if you give someone a beta blocker and they go exercise, they can't get their heart rate above about 140 or 150, depending on the dose. And so that's going to keep that heart a little happier because it can't get that excited, if that makes sense. So treatment for, again, are nitrates. So let's talk about nitrates. Nitrates reduce the workload by dilating veins. Nitrates also do a pretty cool thing with the veins. Veins are called capitance vessels. That's an interesting word. You might not be used to that word. We don't throw it around a lot in English, but capitance vessels are, I guess a good way to describe it is kind of like a deflated balloon, or almost like a big limp pasta noodle, like a like a manicotti that's just kind of big and floppy and open. And they can expand a little to hold some blood. They're not under Veins don't have a whole lot of pressure behind them. Arteries have a lot of pressure behind them, especially those big ones, and they have more elastic in them, elastic tissue. They're more rigid. They can dilate and constrict, but they really can't hold more volume like veins can. Veins are kind of like little reservoirs of blood. And so nitroglycerin can open those things up, make them even loppier, which can reduce the amount of preload or the amount of pressure of blood going back into the heart. So some examples. Nitroglycerin, you see the word nitro in there, or isobromide, or isosobride, dinitrate. It's another example. Here you see the nitrate in here. I want to know who the first person was that sucked on a of like dynamite to find out that nitroglycerin would cause vasodilation. I don't know. But they causes vasodilation. It's a greater effect on the veins. Again, think of the Ni in nitroglycerin. Nitro works mainly on the veins, the In in the veins, that little palindrome. Through the venous dilation, it can decrease the amount of blood coming back to the heart because the veins are like those capitance vessels, sort of like a reservoir for blood. It reduces the pressure. That reduces the preload. And that leads to a decreased volume in the ventricles, which causes decreased cardiac output and reduced workload on the heart. So you can kind of see how all of these things are connected. It's super cool, isn't it? So then it also dilates the coronary arteries that feed the heart, which increases the perfusion and the blood flow and the oxygen and the nutrients to the myocardial cells. And that's why we give it when people are having chest pain or an MI. So if they come or they call and they're like, hey, I've got chest pain, I like to put it this way. Put it on your 3x5 card. I don't know if anybody's got a 3x5 card that they actually write notes on and keep around in their pocket, but 3x5 means give 3 doses 5 minutes apart, 3x5, and to see if the chest pain alleviates. You give a dose, wait 5 minutes, have them sit down before they take it, and see if it goes away. Now, if it's variant angina, or maybe it's caused by some kind of just spastic thing, it might relax. Well, they can try another one and 5 minutes later and see if it relaxes. If they try a third one and it doesn't relax, well, then they need to call 911 because that means they're having a myocardial infarction. And that medication, that vasodilator, isn't working to dilate those vessels. Other teaching, you want to avoid alcohol. It can cause hypotension, low blood pressure. And this is a really one that you'll always see on the NCLEX and in always, so just know this. Never take within 24 hours of a PDE5 inhibitor. You're probably like, what's a PDE5 inhibitor? I don't expect you guys to remember all that, but it's Viagra. So you don't want to give Viagra. You don't want to give nitro within 24 hours of Viagra. And women take Viagra too to help with sexual dysfunction. It's not just a male drug. So Viagra or like sildenafil or tadalafil, which is Cialis. Cialis is actually longer acting, and so you want to be 24 hours free of Cialis before you give a nitrate. So you want to ask about that. Always ask. Just don't assume that people aren't maybe taking that. The reason why is you'll cause really bad hypotension. They both cause hypotension. And if you take nitrate with a PDE5 inhibitor, you just opened up everything and there is no more blood pressure. So that's a bad thing. So tolerance is a common problem with nitrates, with prolonged use of long-acting ones, especially. And so some people take nitroglycerin. They might have in a patch. They might take uh, some other types of forms of it. And so they may be instructed to remove their patch at night or for 6 to 12 hours or so. Nitroglycerin it's not a very stable medication, hence boom in dynamite. So you need to keep it in the original glass bottles. It's not going to explode, but it will decompose. It decomposes when exposed to heat and light. And so you want to keep it in a medicine cabinet at stable room temperature, in its original bottle, all those things. Usually the bottles are like an amber glass that help protect it. So let's move on to medications that affect the speed of the heart. So maybe the pump is moving too fast or too slow. So there are those medications that slow down the pump to help it pump more efficiently. And that might be like a beta blocker. That reduces the effect of norepinephrine on the heart. Again, so like let's say somebody goes into supraventricular tachycardia, a cardiologist might put them on some metoprolol, for example, and that'll help keep that heart rate lower and keep it to the point where it's not so fast, pumping so fast that it's ineffective. Like, I don't know if you were ever in the pool, remember squirting the water and you keep going like this. This is not a very good squirt. You really want to like squirt it hard, right? If you want to go far. This is not effective. And so another medication you might see is verapamil, which is a calcium channel blocker. And we'll talk about CCBs here in about another 2 or 3 minutes. So with CCBs, or verapamil, the way I'd like to think about it is a very rapid treadmill. I use it to slow down the very rapid treadmill of my heart, which is going really fast, going really, really fast. And so I can use a calcium channel blocker to slow it down. Now, there are medications that we can use to slow down the speed of the heart, which we just talked about. And now we got medications that we can use to speed up the pump. So that can help the pump move faster to pump more blood. So let's say somebody's got in bradycardia, and their heart rate's like 50. Then that's probably not good enough unless you're Michael Phelps to get the blood to where it needs to go. And so we can give them atropine, for example. Atropine is an anticholinergic. I like to think of it, to remember it, that it bounces the heart rate up. Like I jump on a trampoline and I bounce up. And so like if a heart's jumping on a trampoline, it bounces it up. And it works by blocking the rest and digest PNS. Atropine is anticholinergic, which means it blocks the PSNS. And so if the parasympathetic nervous system is like brakes for the body. And if I block the brake pedal on the car, all I have is the gas, right? If I stop pressing on the brakes, and I got my car in drive. I don't know if anybody's ever done this. You've got your car in drive, and you take your foot off the brake, your car starts moving. Just like it's just not fast, it just starts moving though. But if you stop putting your foot on the brake, if you use an anticholinergic, and you stop putting your foot on the brake, your car's going to start speeding up. A beta blocker slows your heart rate down. If I stop pushing on the gas, and I don't necessarily have to push on the brake, but if I stop pushing on the gas, eventually it'll slow down. So I don't know if that helps at all. So SNS speeds up the heart rate because you're stimulating those alpha and beta cells, primarily the beta 1 cells in the heart. So that's increasing your heart rate. And a beta blocker slows down the heart because it blocks that action of the norepinephrine on the heart. The PSNS slows down the heart rate. It's like a brake pedal on a car, and an anticholinergic stops the acetylcholine. That's what anticholinergics do. They stop the acetylcholine, which speeds up the heart rate because acetylcholine slows everything down. Acetylcholine slows it down. And if we block the slow, then it speeds back up because we blocked the slow. So if I stop pressing the brakes, it'll speed up. So here's just an easy way to remember that. And here's a heart bouncing on a trampoline for bradycardia. And then here's the Brady Bunch jumping on a trampoline for atropine. So you can think about that, a trampoline, atropine. And I used AI. I said, I want a picture of a heart bouncing up and down on a trampoline. It gave me this. And then I said, I want a picture of the Brady Bunch with their little hairstyles. And it gave me this one, jumping up and down on a trampoline. Is that interesting? I've never worked with AI before. But that's for you. There's a couple other ones that I've thrown in here too that you'll like. So let's talk a little bit about calcium. Calcium significantly affects the length of time it takes for the heart to depolarize or contract. The squeeze or the pump. This is depolarization. It's that whole process of and then it has to repolarize and reset. Pump, reset. Pump. So, depolarization, repolarization, depolarization, repolarization. So think of it this as the length of time it takes for the heart to fill up and pump one time. So that's different than the heart rate, which might be 60 to 100 beats per minute if it's normal, right? That's the number of beats per minute. What we're looking at here is how long does it take for the calcium ions to basically move from the SA node, the sinus atrial node, through the AV node, down through the bundle branches, down through the Purkinje fibers. That's what we're talking about here, is that pathway. How fast does that pathway work? If it goes too fast, then we can have things like VFib and other types of things that are no good. If it's too slow, we might have a bundle branch block, which is, again, not a good thing. So this is way back to your A and P, your anatomy and physiology, and here's your cardiomyocytes. And calcium moves from the neighboring cells to depolarize it. It's basically a wave of calcium going, woo, woo. That's what's happening when you're depolarized. And so it goes through these little gap junctions, which allow the calcium ions to flow on between the cells. Calcium channel blockers block these puppies. That's what they do, which means it makes it harder or slower for the calcium to get out. So it slows things down. All right, now the 50,000 look view here, not to freak you out, but just to give you a little bit more background. So this is what a single heartbeat looks like. And you don't need to know this for your exam, but it's helpful to know the way a drug works for the mechanism of action. So I'm just going to kind of zoom in here just a little bit, try to frame that. So here we have our P wave, our QRS complex, and then going into our T wave. And so as you guys haven't probably learned how to do this yet, this is the P wave is where your atrium depolarizes. Boom, there's a little bit of electrical action. The QRS complex, this is the big squeeze of the ventricle. This is the ventricle depolarizing. And then you get a little bit of repolarization in here. Can't see it because there's so much action going on comparatively with the QRS complex and for the atriums to repolarize. But over here, you see the T wave repolarizing, and this is the repolarization of the ventricle. So atrium contract, like boom, boom. So this atrium squeeze, and then the big one, QRS, is the ventricles are squeezing. Boom. That's this big boom. Okay, and then this is the ventricles. The atrium actually relaxes right here. Can't see it. It's hidden in that big wave. And then this is the ventricle repolarize. And you'll learn all about that later in MedSearch too. But I just wanted you guys to see this. So what's going on there in the patho, it's kind of cool. So there's this huge pump of sodium coming in. And you can think about it as summit. So like it's coming up like a summit to a top of a mountain. And you see this little plummet here. This is potassium moving. And then you have this continue, which is calcium. It's kind of going along here. And then you have this more plummet here. And this is the potassium flowing out of the cell. And this is all due to, this is how what's going on in each individual cardiomyocyte. Boom, an action potential for cardiac action potential. So the thing I wanted to point out here was not all this, though it's super cool. So you remember summit, plummet, continue, plummet. That's how you can remember the summit, plummet, continue, plummet. So sodium, potassium, calcium, potassium. But I wanted you guys to take a look here. And so you see we have verapamil and diltiazem. These are the two calcium channel blockers that work on the heart. They work right here. They work by slowing the amount of calcium that's happening right here. And that's how they work, to slow down the amount of calcium movement and the speed of the contraction and the speed of what's going on through the depolarization cycle of the heart. So then we have that. And then we have amiodarone, which is a potassium channel blocker. We have a beta blocker down here, our propranolol and metoprolol, for example. And over here we have sodium channel blockers. And you might see, like, for example, lidocaine. Lidocaine is something that we use. It's an ACLS medication. We also use amiodarone over here. So this is why they work. You don't need to know this, but sometimes it helps just kind of go, oh, that's interesting. It gets you excited. At least it gets me excited. Maybe I'm weird. But anyway, here's medications that stabilize the heart rhythm. Here's sodium, calcium, and potassium blockers. You don't need to know the sodium channel blockers or the potassium channel blockers. I didn't see them on your the stuff that Professor Bayes wanted you to know for your exam. So sodium channel blockers, though, those are like lidocaine and in cane, like benzocaine. Yeah, they work the same way. They block sodium. That's why you can't feel things like Novocaine when you go to the dentist. It's a cane. It's blocking sodium. That's how it works. Really cool. So potassium channel blockers is like amiodarone, and amiodarone actually works on most of those blockers, which is why it's such a great drug to stabilize the heart rhythm. And we use this in ACL, so then it all comes together. Eventually, trust me, folks, you'll love this when you get a little further along. It gets really cool. So you should know calcium channel blockers for your exam. CCBs work by blocking the movement of calcium in the heart and the arteries. When we just talked about how that works, it slows it down by blocking these gap junctions. Isn't that cool how that works? So because we're slowing those things down, that slows down the depolarization and the conduction speed. So let's go back to some of those terms earlier. It slows down the heart rate, which is negative chronotropic. Remember chronos for like chronograph? That's how the speed of your heart rate. And so negative means it slows it down. It reduces the squeeze, which is a negative inotropic. Think I know, muscle. That's the Greek word for muscle. I know, fiber. It lowers blood pressure due to arterial dilation. And some examples of that, verapamil, the very rapid treadmill, and diltiazem. Say, duh, it's time for Zen because the heart's all freaked out. It needs some Zen. Diltiazem. That's how I remember those. And those two have a very definite effect on heart. VD, remember, very definite effect on heart. They're the ones that work on the heart. The other cardiac, those are called non-selective calcium channel blockers because they work both on the heart and on the blood vessels. Now, selective calcium channel blockers mainly dilate the arterioles and arteries, and they don't really work on the heart a whole lot. So they can be used for things like high blood pressure or maybe Raynaud's disease because it pops those arteries open that are being vasospastic, or you can use them for some angina or chest pain, that type of thing. But it doesn't work on the heart rhythm. That's what we're talking about here. So those end in dipine. So nifedipine, amlodipine, notice the suffix dipine. And the way I like to think about that is this cute little cow I made for you. Dipine fence blocks dick cows. And we'll talk about it in just a second. But remember that these are NA, nifedipine and amlodipine, nifedipine and amlodipine. They're NA to the heart. They're not applicable to the heart. They don't work on the heart. They only work on the blood vessels. So then these are the couple of the other ones. I'm like, all right, AI, give me a heart running on a treadmill really fast for verapamil. And so it gave me this. And so that's my very rapid treadmill for you. And that's one of the ones that has a very definite effect on the heart. And works mainly on the arteries and the arterioles and the heart. Now then we got diltiazem. Duh, it's time for Zen because the heart's all hot and brother, dude. It's crazy. You gotta slow it down, man. Has a very effective effect on the heart. Then you have nifedipine and amlodipine, and that's the pine fence that blocks the cows, and that's Na to the heart. It's not applicable to the heart for nifedipine and amlodipine. So now you know those only work on the arterioles and the arteries. So teaching for calcium channel blockers. No grapefruit juice. It can cause significant hypotension due to vasodilation. It can cause headache, dizziness, flushing. It can cause reflective tachycardia with the non-selective type because those are the ones that are selective for the heart. The verapamil and the diltiazem, those are the non-selective ones, and they control the heart contractions, and so they can cause reflex tachycardia. That means that the heart gets fast. Even we slowed it down, but now it's getting fast. That's reflex. Also, grapefruit juice. It inhibits the metabolism due to greater effects, which gives you greater than expected effects of drug or toxicity. And so one of the things to remember with cardiac meds is, for the most part, when it comes to the NCLEX, just don't drink grapefruit juice. The only reason grapefruit juice exists is so it tastes good in a Paloma. And if you don't have tequila, then, you don't need grapefruit juice. So meds that cut cholesterol, they help with narrowing the blood vessels, especially the coronary arteries due to atherosclerosis, which is that plaque buildup. There's the HMG-CoA reductase inhibitors. Most people never call them HMG-CoA reductase inhibitors, blah, blah, blah. They don't call them that. They call them statins because they end in statin. And so those are your drugs like rovastatin And they're great drugs, but they can cause liver dysfunction, they can cause muscle pain, and they can cause rhabdomyolysis, which is really bad muscle pain. Actually, what's happening with rhabdo means that you're basically your muscles are starting to break down, and that's not a good thing. But this can sometimes happen with weightlifters if they're having way too much like plant-based protein. I think it can cause rhabdomyolysis too. So rhabdomyolysis is a bad news, but risk benefit. You know, if the person wants to keep eating their bacon and not exercise, then they probably should be on a statin. I take a statin because I like my bacon and I don't like my exercise. Don't take them for pregnancy. Oh, pregnancy. These are bad. Encourage lifestyle modifications. Yes, I know I should give up my bacon. No grapefruit juice. That's pretty much every cardiac med. You want to take them at night? Why? Why do you want to take them at night? Because your body makes cholesterol at night. Yeah. So statins work at night. So you want to block, you want to take them at night because that's when your body makes cholesterol. Here's a great little like 5-minute YouTube on statins. Other medications that cut cholesterol are fibrates, which are fibric acid derivatives. They help to block cholesterol. Bile acid sequestrations help bind cholesterol during digestion. And so you might come across this on an NCLEX exam. And if anything's binding anything in your GI tract, you can probably expect it'll cause either diarrhea or nausea or something. In this case, it can cause diarrhea. Nicotinic acid, I'm pretty sure on that. Might be constipation. Maybe it does. I don't know. Nicotinic acid is like niacin. Sometimes people take niacin and over the counter. And then you have this one here, Repatha, which is a ipilimumab. It's a monoclonal antibody. You can tell by the MAB. But Repatha works in a really interesting way to help lower some other types of cholesterol that you can't touch otherwise. It's pretty interesting if you take a look at a total cholesterol score. Repatha is a good one for that, but it's expensive because it's a monoclonal antibody. It's pretty new. So medications that affect clotting. So you have anticoagulants, and these prevent new clots. Anticoagulants prevent new clots. They don't break up old clots. They prevent new clots. There's a couple of different types. There's a vitamin K inhibitor, and that's going to be warfarin. Trade name Coumadin. It prevents clotting. The way I remember that is you bleed a lot in warfare, okay? Warfare in, right? In warfare, okay. And so vitamin K is the antidote for warfarin. You don't have to give up vitamin-rich foods. Say they really like kale. They don't have to give up the kale. They just have to keep the amount of kale consistent from day to day. My personal way of eating kale, I tell people to prepare with a little bit of extra virgin coconut oil because then it makes it easier to scrape it in the trash can. So the therapeutic range for warfarin is 1.5 to 2 times the control value with up to 3 or 3.5 for heart valves. That's going to be provider driven or policy driven at your hospital. It's highly protein bound, 99%. And so if you remember your protein binding, that means it can cause a lot of complications because it's one of the most protein bound drugs available. Another side fact, you might not know this, but warfarin is what's in decon. It started out as a rat poison, and it works because it causes rats to have internal hemorrhaging, and that's how they die. So they basically bleed out inside. So, but if they had like some kale to chew on or some leafy greens to get that vitamin K, they'd probably be just fine. So another one is heparin. This actually, its antidote is protamine sulfate. The thing you need to worry about heparin is HIT, which is heparin-induced thrombocytopenia. You'll learn about this in med-surg, so you don't need to worry about that too much here. But heparin-induced cytopenia can happen, which basically means that they're starting to clot again. It's just not good. It's not a good thing. Just not good. Their thrombocytes are just dropping. And so they stop the ability to clot. They stop the ability to clot, and that's just and then some other things happen. It's just not good. It's not good. It's no bueno. So you want to stop the infusion. Usually measure heparin with APPT as INR, which is the therapeutic. I should write this in here. INR is the therapeutic range for warfarin, and you can think about that because it's IN for warfarin. And then APPT has got heparin, and heparin's got a P in it, and so does APPT. So normal range is about 30 to 40 seconds for heparin. The therapeutic range is 60 to 70 seconds. And a way to remember that, it's like, what's the therapeutic range for APT or for heparin? And like, I don't know, give me a minute so I can recall it. Give me a minute. 60 seconds. So there's also low molecular weight heparin, which is Lovenox. A lot of people get this post-surgery. And so it prevents blood clots like DVTs and things like PEs and stuff like that. Then you also have all antiplatelet agents, which prevent platelet aggregation. And this is going to be like clopidogrel or aspirin works the very similar way. They're both antiplatelet agents. And so this is Plavix. Clopidogrel is Plavix, and it works to prevent platelet aggregation. And so people who have a stent, they'll take this because it prevents the platelets from aggregating on, around the stent and causing another clot. It can increase the risk of bleeding or hemorrhage because it stops the platelets from aggregating. So ASA or aspirin and clopidogrel are sometimes used together, so they work a little bit different. So you'll see these oftentimes used together, but you want to avoid the use of ibuprofen or NSAIDs. And so you might come across a question on your NCLEX that says, which of the following should the patient use for a headache? And with Tylenol's not an option on there, but you see ibuprofen or naproxen, run away. You don't want naproxen or ibuprofen or any other NSAID there. Aspirin, probably not ideal, but Tylenol would be better. So a way to remember this is I asked AI, I'm like, give me a picture of an old guy eating a bowl of oatmeal, because who has a bowl of gruel, right? In a diner. And so this is Al's Grel, Grel. So you can think of clopidogrel, all of your antiplatelets, then that fat company end with Grel, Grel. And today's blue plate special for platelets is a bowl of Grel, spelled Grel. And notice Al is alone because he's eating Grel, which prevents other people from aggregating around him. And he's also sitting on a trash can that's been overturned. And is that comfortable? No, it's not comfortable to sit on a trash can, especially got this nice, comfy bench seat here. That's causing him some ass pain. Yeah, some ass pain. That's a pain in the ass sitting on this hard, overturned trash can. And so aspirin is an antiplatelet too. So that's why it's at Al's Grel. And that's the home of the blue platelet special. Okay, medications that break up existing clots are thrombolytics, and these are literally clot blusters, and they end in place, PLASE, like alteplase. And you can remember that ASE is going to be like your enzymes that break crap up. So anything that's an ASE is going to break up something. And so this ends up breaking up clots. And so you can use these things for MI. Alteplase can be used for an MI. Oftentimes they'll try to get in to do like cardiac cath, but in, say, down at Spanish Peaks down in Walsenburg, they don't have a cardiac cath lab. So they will use Alteplase if they can, or they'll fly you out. And so they'll use this for MI or for pulmonary embolism, which again, due to a blood clot, or an MI due to a blood clot, or an acute ischemic stroke, or embolytic stroke, which is caused by a blood clot. Again, breaks up blood clots. But you don't want to use this for hemorrhagic stroke. Never, never, never. Because that's the kind of stroke that causes bleeding in your brain, or like a brain aneurysm, because now you blew apart the clot that stopped the bleeding in the brain. So now they're just going to keep bleeding in the brain. Bad news. So it's contraindicated with recent surgery or CPR or hemorrhagic shock. Stork. That's funny. Pregnancy, peptic ulcers due to risk of bleeding and stuff like that. So there's some guidelines around that. You usually need to give it within about a 3 to 4 hour window, depending on protocol of your location. It lessens the risk of bleeding. To lessen the risk of bleeding, rather, you want to start your IVs before you give it. So once you give it, it starts breaking up clots, and so you don't want to necessarily give any additional shots if you can. You don't want to start extra IVs or give IM injections if possible. If you do give an IM injection, you want to use a small needle. You want to use direct pressure to kind of keep the bleeding down because they're not going to clot. It breaks up clots. Hypertension. Oh, and you want to wait 24 hours before you give them anything like aspirin. So that's wait at least 24 hours. Ugh. There we go. All right, hypertension. Some drugs that break up hypertension or high blood pressure. You're going to have diuretics. They reduce sodium and fluid volume. Sympatholytics, which means those are going to be alpha and beta blockers. Sympatholytic. That sympatho means SNS. Lytic means to break it up or to stop, blow it apart. So they cause vasodilation or they reduce your heart rate. You have your direct arterial vasodilators, which are like your calcium channel blockers. And then you've got drugs that affect the renin-angiotensin system. And some examples of those are going to be your ACE inhibitors. So you have ACE2, angiotensin receptor blockers as well. And they work by reducing aldosterone, which reduces the amount of sodium and fluid volume. And they also reduce the amount of angiotensin 2, which is the reduction of vasoconstriction. Angiotensin 2 is a really strong vasoconstrictor. So if we can stop vasoconstriction, that will reduce, we're opening up those pipes. That makes sense. So reducing volume by causing people to pee more, but reducing sodium, we're also reducing the amount of vasoconstriction. So that's how they work. Here's the RAS system in general. So you can use a like a direct renin inhibitor. That'll help reduce blood pressure. You can use an ACE inhibitor. Note they end in pril, P-R-I-L, and that blocks ACE. Angiotensin, so it stops angiotensin from being able to form angiotensin 2. Then we have a receptor blocker in here, this angiotensin receptor blocker, angiotensin 2. If we can stop it here, these are actually different medications that all get us to the same thing, which stops that formation of aldosterone and angiotensin 2. So these reduce pressure in the pipe. They reduce blood pressure. And so let's take a look at them a little bit. So ACE inhibitors end in pril. ARBs end in sartan. So an example of that. So this would be like enalapril. We'll go back here. Catapril, benzapril, those are ACE inhibitors. Angiotensin receptor blockers end in sartan, like losartan and valsartan. ACEs and ARBs work by blocking the RAS cycle. They block angiotensin 2. Angiotensin is a vasoconstrictor, so by blocking angio 2, you get lower vasoconstriction. And by blocking angiotensin 2 also stimulates aldosterone, which causes retention of sodium, and therefore wherever sodium goes, water follows. So if you block angiotensin 2, you get lower sodium and lower water. So don't take these during pregnancy. Side effects. ACE inhibitors, they can cause a cough. And that's due to the extra release of bradykinin in the lungs. ARBs don't cause a cough because they don't work in the lungs. They work elsewhere. About 20% of patients on ACE inhibitors develop a cough and need to be put on an ARB. And so there's a little saying here. It says, if you give them an ACE and they cough in your face and you hit them in the ARB, hit them in the ARB. If they cough, then you want to give them an ARB because there's no cough with the ARB. So the other side effects, you can think of ACE, ACE, so angioedema. That's going to be more common in African American populations. Cough due to the excess bradykinin release, and then you have an elevated potassium hyperkalemia. So if they're on a potassium-sparing diuretic or they take potassium supplements, then they need to be be aware of hyperkalemia, and I put the signs and symptoms down below. Remember that the normal range for potassium is 3.5 to 5, and you can remember that a Pound of bananas is usually 3.5 to 5 bananas in a bunch. So they can cause ACE inhibitors can cause profound hypotension with initial dose. So sometimes they'll advise taking the first dose at night, and that's because if you're going to get really dizzy and pass out, you're already laying on your bed and you're not going to hurt yourself. That's the reason why. They need to be observe themselves for orthostatic hypertension, which means don't get up really fast in the morning. Sit, dangle your feet off the edge of the bed for a minute or two before you get out of bed, or you can fall over and hurt yourself. Make sure the patient's not dehydrated when you're starting an ACE inhibitor or an ARB. And that's because it can cause acute renal failure with heart failure patients due to low glomerular filtration pressures. So that's just kind of a side effect. You want to be careful about that. Side effects of ARBs are pretty much the same as ACE inhibitors, except for there's no cough with an ACE inhibitor. Pretty much the rest are the same. Don't take those during pregnancy. All right, let's quickly, we're almost done here. We're going to hit diuretics. We hit these for the renal lecture, so we're not going to hit them again too hard, but there's thiazides, which you're going to see more for hypertension. They're weaker than loops, which would be like furosemide. A few, but not all drugs ending in ide are loop diuretics. Ide's a pretty common chemical ending for a type of salt. So you get calcium chloride, sodium chloride, and those aren't loop diuretics. They're salts. So ide is a way of looking at that, but it's not foolproof by any means. They work by blocking the reabsorption of sodium in the kidneys, and less sodium equals more P and less water volume in the blood, because wherever sodium goes, water follows. And sodium is going into the urine because it's not being reabsorbed by the kidneys, and therefore it's flowing into the toilet. Your water is going to flow into the toilet. And so that causes you to lose blood volume, which causes you to lose blood pressure. And that can be a good thing. It can also be a bad thing. So don't push furosemide too quickly. It's ototoxic, which means it's bad for the ears. And monitor potassium and fluid output. All right, drugs that increase the power of the pump. Remember, increase the power of the pump. So there's going to be cardiac glycosides, the primary one, and that's digoxin. It's been used for about 200 years. It's now considered a second-line agent. Actually comes from, I think, foxglove, if I'm not mistaken. A plant, so it's been around a long time. It's used sometimes for cardiac dysrhythmias such as AFib. Going back to those words again so we can practice them. It's a positive inotropic agent, which means it increases the muscle contractility. I know. It's a big squeeze. So it's a positive lusotropic, which increases ventricular relaxation in man. And so the more relaxed the ventricles are, the faster they relax, the faster they can fill up, and the faster they can pump. And the more they can pump. And they're just sort of more loosey-goosey. It's a negative chronotropic, which means it decreases the heart rate. So you're getting a better squeeze. It's more powerful. It's fuller because it's more relaxed, so it can fill up more. It's slower, so it can be more intentional, and it decreases the conduction of the AV node, which means that your heart rate's more stable, which is why it works for AFib. Note, in women, digestins can sometimes do more harm than good and might actually increase mortality. All right, digitalis toxicity is a major concern. There's a narrow therapeutic range for digoxin, and these are signs and symptoms, and you will always see these questions on the NCLEX, so know these. Anorexia, diarrhea, nausea, and vomiting. Why? Most of the time when we're having a side effect of something, a toxic effect, it makes us feel like crap. That's why we feel like we got diarrhea, nausea, if we got diarrhea, nausea, vomiting, we don't want to eat. So that's why we're feeling anorexia. That means we're not like, anorexia nervosa. Just anorexia means you don't want to eat. Bradycardia, that means the heart rate's slow. We've overdone the slowing. Remember, look up here, it's negative chronotropic. It decreases the heart rate. If we give too much of it, it's going to decrease it too much. And so it's really important for the nurse to check the apical, which is the heart rate on the chest, for at least 1 minute, to be sure that it's above 60 or whatever's being the prescriber is driving. But it's usually 60 for the NCLEX world. It's got to be greater than 60 or you don't get it. And a classic test question is if you see a visual disturbance, halos around objects, or you see yellow or green floaters, then you probably have a digoxin toxicity. You'll see this question. It's just something you need to remember and memorize. PVCs and other dysrhythmias are often treated with things like phenytonin, which is an anticonvulsant. And then also, I don't know why that's so to know that, but this should be here. Low potassium increases the risk for digitalis toxicity. And so if they have low potassium, that's one of the things you need to monitor if they're having any kind of issue with vaso for digital this toxicity can increase with low potassium. So here's just a quick little image here for you with some vasopressor and inapropes. Don't necessarily need to know these, but you might want to know them someday if you're interested in cardiac ICU. So let's do a couple of questions. Which of the following is a contraindication for digoxin administration? We just talked about that, right? So we want to listen to the apical pulse, and we want to make sure that we listen for at least 1 minute, and we want to make sure that the heart rate is above 60 if we give it. So if it's below 60, then it's a contraindication. So it's asking what is a contraindication. So that means we don't want to give it if we can give it if the blood pressure, that's okay. That's a little high, but it's okay. Heart rate above 80 is all right. Heart rate below 60, that's what we're concerned about. So heart rate above 60. So question number 2. Nurse is providing instructions for a client who's receiving warfarin sodium, which is warfarin, Coumadin, which statement made by the client indicates a need for further instruction. So when you see these questions, need for further instruction, that means that whatever they're doing is bad. So they need some correction. Which of these statements by a client means that they need to have some correction? And I will observe the color of my urine and stool. No, that's good because you want to be sure that they're not bleeding. And so I mean, look for black tarry stools, right? That would be like GI bleeding or blood in their stools or in their urine. What about drinking alcohol? Yeah, you want to avoid drinking alcohol, right? Because alcohol thins your blood and it can cause you to bleed more, right? Yeah. What about take your medication at the same time every day? Yeah, that's a really good thing. So which one of these is not like the other? It's this one in the middle. Well, why don't we read it? Let's see. I'll take Ecotrin, aspirin for my headaches. Do we want to take any kind of blood thinner with warfarin, any kind of aspirin? The answer is no. Doesn't matter if it's enteric coated or not. No aspirin of any kind with warfarin sodium. So number 3, a client with atrial fib is receiving a continuous heparin infusion at 1,000 units per hour. The nurse observes the client is receiving the therapeutic effect based on which of the following results. So, oh man, what's the activated partial thromboplastin time, the APT time, APPT for heparin? Gosh, I don't remember. Can you give me a minute? Can you give me a minute while I think about it? Give me a minute. So what is it? Yeah, the answer is 60. At APT, time is 60 seconds. That's the normal range. It's going to be, the normal range is 20 to 36 seconds, and the therapeutic value must be 1.5 to 2.5 times the normal value. And the client would be considered therapeutic if it was 60 seconds. Warfarin is going to be INR. Remember, IN in warfarin. Okay. That's what you're monitoring for that one. The action of an ACE inhibitor interrupts the renin-angiotensin-aldosterone mechanism, thereby producing which of the following? Reduced renal blood flow? You're like, no, not really. Reduce sodium and water excretion. I'm like, no, let's see. I'm wanting to take it to reduce blood pressure, right? So that doesn't make sense. If I do that, that'll increase my blood pressure. If I increase my peripheral vascular resistance, I'll increase my blood pressure. So I don't like any of those. How about this one? Increase sodium excretion and potassium reabsorption. Absolutely. So this prevents aldosterone and angiotensin, right? And aldosterone and angiotensin increase sodium excretion. So if we inhibit that, then we will increase sodium. And it also causes E for elevated potassium, which causes potassium reabsorption. So there it is. Increased sodium excretion and potassium reabsorption. It's indicated by aldosterone. ACE inhibitors increase renal blood flow. Peripheral vascular resistance is decreased by vasodilation of ACE inhibitors. So there you go. All right, and last one, vitamin K, or on this one, I think. Intravenous heparin therapy is given, I'm sorry, that's not the answer for this one. I read the wrong line. Question 5. Intravenous heparin therapy is prescribed for a client. While implementing this prescription, nurse ensures which medication is available on a nursing unit. What do you want? What's the antidote for heparin? Is it vitamin K? No. Warfare is bloody. Okay, that's going to be warfarin, right? Coumadin. Heparin is protamine sulfate. And maybe you can remember the P for heparin and the P for protamine sulfate. So that might help. Potassium chloride, that's the salt substitute that people sometimes take if they're on a low sodium diet. And aminocoporic acid actually helps you, they can get that to help you stop bleeding. So protamine sulfate is the antidote for heparin. Vitamin K is the antidote for warfarin. Know them both. Know these both. You'll see these often in questions. That's it. That's our cardiac review for this week, and hope you guys enjoy it. More later. We'll see you next week. Bye now.